Ready? All right. Hello and welcome to this Speech, Language, and Communication virtual roundtable event put on by the SATB2 Gene Foundation. I am here with an incredibly accomplished group of speech and language pathologists. Each have been personally recommended by one of our families to collaborate on the topic of their noted success in verbal speech development for a client affected by SATB2-associated syndrome. While each family has given permission for their children's success and struggles to be highlighted in this discussion, we will do our best to keep patient information generalized and to protect privacy. Please, recommendations of our panelists about SATB2 specific therapy is a reflection of their own specialized training and experience and should be used to inspire collaboration on the topic of best practice ideas, not a guarantee of individual success with implementation. Ashlyn Thomason is here representing the SATB2 Gene Foundation's Medical and Scientific Advisory Board. So without further ado, I will turn the microphone over to Ashlyn to present the most up-to-date speech, language, and communication data for the children affected by SAS as seen in our research clinics.
Thank you so much, Casey. So I am Ashlyn Thomason at Arkansas Children's Hospital. I work in our outpatient clinics here and have been privileged to be a part of our SATB2-associated syndrome clinics that have been held at Arkansas Children's. Those are multidisciplinary clinics, and so for the families who've experienced those, you see a ton of professionals. With in our clinic, we had 3 speech language pathologists, 2 others in addition to myself. SAS is a speech-heavy syndrome, and so we thought that we should get, 2 hours with these patients to capture what they're like in order to gather data to inform families and inform best practices, but we got 30 minutes. And so I know that some of these data come from parent report, criterion reference tools, some elements of standardized test screening procedures, and basic observations, rather than all formal standardized evaluations. And so the data, I think, are good to give some overarching information to help guide therapists, but unfortunately can't be super patient specific. So as part of our clinics in 2017 and 2018, we saw 61 total individuals who have SAS. We saw toddlers through some young adults, which was wonderful, had a good gender variation, and kids with all sorts of mutations associated with their SAS. If you want to go ahead and go on to that next slide. We were wanting to know how these children communicate overall. And we found that 72.1% of these individuals are primarily nonverbal communicators. We had to define this for research, and in our definition, we defined a nonverbal communicator as a person who uses approximately less than 10 words in a day, and whose family reports that they generally use other modalities of communication primarily to communicate. And so we, in speaking to the parents and in observing the child, would look and see how we thought they were communicating the most. And so that's where we got this breakdown of the 72% as being primarily nonverbal. We found that most children are reported to use gestures as their most common communication modality. That was at 59%. They either use these gestures alone or were in combination with formal ASL signs or with some other form of AAC, possibly low or high tech. Go ahead and advance. First words generally come late. For children with SAS, we found that average reported age of first words was at 27.6 months, and neurotypical children, that's at approximately 12 months of age. And we had some kids saying a first word as late as 66 months. These data only include individuals who have spoken a first word, and that was 44 out of the children for which we had data among that group of 61. So expressive vocabulary, data came from parent report. And so really difficult to get a complete picture, we would love to do formal testing to know more about these abilities. Parents gave us an estimate or a formal number. Those numbers, of course, were more reliable and valid for the children who don't have many words. Those parents know for sure they have 11 words, and let me list them for you right now.
Mm-hmm.
For the children with more spoken language abilities, they would sometimes give us a range. Often that range was large. For the purpose of research, we would get that median age of a parent said they have between 50 and 100 words. Our data point would be 75, for example. So on this slide, you can see that the overall average in this cohort from 2017 and 2018 was 28.6 words. That's ranging, of course, from 0 to 500. For those data, that includes 3 outliers, children who had spoken vocabularies of 200, 350, and 500 words. Those 3 outliers are not including some other kids who had some very high level abilities. But for the purposes of research, we had to include kids for whom we had hard data. There were a few really verbal children who came to our clinics, and the clinician either didn't write down a number or they wrote something qualitative like unlimited vocabulary, large vocabulary. And so there may be some children with SAS who are more verbal than 500 words. And again, even the parent who estimated 500 said it may be well over that. It's kind of hard to put an exact estimate to it. If I had to give you a number, even as a speech language pathologist, on what my daughter uses, I don't know. So not exactly reliable data. But excuse me, if you exclude those 3 outliers, that average falls to 10. And so you can see on this slide the age breakdown. Around 2.5 words for children under 3, 6.2 for 3 years, 1 month through 6, and on up. 16% of individuals with SAS had no spoken vocabulary words. Those parents haven't heard that first word yet. Go on and advance. All right. So we wanted to know through our clinic, as we combine this data and looked at these children across their lifespan, again, not through their whole life because we went through young adults only, but sorry. Does spoken vocabulary appear to increase with age? Do these children tend to plateau at a certain age? With the data that we have, we can see that spoken vocabulary in individuals with SAS, unfortunately, doesn't necessarily appear to increase as a function of age. Next slide. Where we get more stratified complete data is in the arena of receptive vocabulary, how these children are understanding. For this portion of capturing these children, we used a test called the Tackle-4, and we used a subtest of the standardized measure. So for this subtest, children are shown 3 pictures, and they are given a word. These words start at very common and low level, something like yellow, on up to a higher level, less common words like ascending. And so they're presented these 3 pictures in the word. They have to select the picture that corresponds to that word. Of course, some of the correct responses could be included by chance, but that is all accounted for in the standardization of the measures. Generally, with a test like this, what you would report is a standard score, a comparison to normal. For most of our kids, when we get this data, it's low. They're all severe. That doesn't give us information. But what does give us information and some stratification across these kids is their raw score. How many individual words did they get right for this measure? And so that ranged from 0 to 38, and that average was recognizing 10.1 of those words. We had some kids who just couldn't participate, who 29% who didn't have the joint attention or the pointing abilities to select a correct response. And so we don't really know what their receptive vocabulary abilities are. They're probably not nil. Of course, they're understanding some things, but those data were also included. So if you go to the next slide, we see receptive language as compared to same age peers. So this goes back to that scaled score where we're looking at kids compared to neurotypical. So in this, you can see that as a function of age, children with SAS are generally closer in their receptive single word vocabulary abilities to their peers when they're younger. But as the bar gets higher and higher and those neurotypical children are understanding more and more words, as we compare our SAS individuals to those neurotypical children, their skills look lower and lower. And so there is another image that's not included here, but it's more encouraging when we look at those raw scores as compared to the lifespan. The general trend is up. So what's really great is that as a function of age, it appears that these kids know more and more words, that the receptive vocabulary appears to continue to grow. All right, then moving on, mean length of utterance. We got this data from parent report and from transcriptions of language samples from within the room. So the mean length of utterance among our children who were reported and observed to be primarily verbal communicators was 2.39 words. So utterance length doesn't just come down to words, it also comes down to some grammar units. And so how these children are putting together utterances. So 2.39 words was kind of that average length. So for our verbal communicators, they're using pretty short utterances, short sentences. And that ranged from single words up to 6.75 mean linguistic units. When you take out those high functioning kids, those very verbal individuals who we talked about before who had, up to 500 words, that drops to 1.67. So you hear kids mostly use single words, but intermittently use those 2-word utterances. And if you'll move on to that communication function classification system, the CFCS is a 5-point scale or categorization system that helps to capture how reliable children are at getting messages across and receiving messages with familiar and unfamiliar communication partners. And so in this system, we saw that consistently in about 73.3% of kids, they exhibited problems with reliable communication with unfamiliar partners. So when they're with family, their speech language pathologist, they can most of the time get their message across, but when they are communicating with an outside person, they don't necessarily know what those gestures mean. The CFCS not only counts verbal speech, but also counts any modality of communication. And so we wanted to see with these kids who are nonverbal communicators, AAC users, how they're functioning. And so communicating with outside people is a problem. And then 16.6% of our kids were rated as a level 5. So seldom an effective sender or receiver of information, even with familiar partners. They're having a lot of communication breakdowns even in the home, a lot of frustration, and parents don't necessarily know what that message is. And you can see on the next slide that overall data across the lifespan, and you can see that there's quite a range in how these kids are categorized. We only had one included among these data who's a level 1 who is a reliable sender and receiver of information, even with unfamiliar communication partners. And then moving on to Apraxia, this was probably the most surprising and maybe informative finding of our clinic. So the majority of kids coming to this clinic, we noticed just in our preparation for the clinic and receiving medical records, already had a diagnosis of apraxia of speech. And so we were wanting to do some apraxia screening procedures. Our plan was to use a tool called the LAT Apraxia Screening Summary, where we had kids repeat some words 3 times and look at their consistency, not their accuracy, but can they repeat a word consistently. Consistency across trials is only one element that you look into for apraxia, but it is it is a tool that can be used to help identify a feature of apraxia. What we found is that in our individuals with SAS at camp, very few of them could participate in the LAT. They would get fixated on one of the pictures and keep saying it instead of going through all 12. Dinosaur, dinosaur, dinosaur. So what we really had to rely on were our transcriptions of known adult targets. And so if they were saying backpack, they pointed to the backpack and they said backpack, okay? We were trying to get to say backpack or an LAT. We found all had signs of apraxia was noted in 36.1% of our cohort. So we looked a little bit at resonance with a nasal mirror and perceptual measures. And then as we were able to have a clinic from year 2017 to 2018, we were able to look at speech progress. And so we were able to see 9 kids back to back to see what they looked like from year 1 to year 2. So 77.8% made gains in their receptive vocabulary raw score, 44.4% made gains in reported expressive vocabulary. And there were a couple of kids who had no expressive vocabulary gains. From year 1 to year 2, they didn't even see one more spoken word in what they were seeing. And so this is the data for that tackle, that subtest standardized measure. And so you can see in these kids, most all kids in the 2018 year, represented in that red bar, went up in their raw score. They were able to recognize and understand more words. There were a couple of kids who were lower, a kid who dropped from 1 to 0. And let's see, I thought that there were 2. Anyway, it's very rare for them not to have gains in receptive vocabulary, single word vocabulary. That's kind of what our data showed. So our recommendations in spending, yes.
Can we do the recommendations with you privately at the end and just skip to the roundtable kind of?
Love it.
That would be perfect. Thank you so much. I'm sorry to cut you off.
No, that's okay.
So, Allison, I see the big screen. So I'm going to throw it out to the roundtable. How do you diagnose, or did you diagnose apraxia in your children with SATB2 or SATB2-associated syndrome? Let's see. Who is Deborah? You have a couple that you've seen. Could you start with?
Okay.
How we're diagnosing that?
2 clients, one has been officially diagnosed, and one is been diagnosed but not registered, or I'm not sure. But anyways, the 3-year-old is a girl, the 12-year-old is a boy. The boy has repaired cleft palate. So for both kids, they have very little speech. However, my 12-year-old, he can just go right along. He's got an iPad that he can use as augmentative communication. He has a few gestures, whereas my 3-year-old is using sign, and she's good. And both of the kids are combining words from a language perspective. From a verbal perspective, they both struggle. I use prompt. I'm actually a prompt instructor. And ironically, both kids I have not seen since COVID hit. And I am super busy with telepractice, but both those kids not, because they are so prompt dependent, and probably other, attention issues and other things as well. But the verbal motor planning difficulties and not knowing where or how to make those motor transitions from motor link to motor link to motor link is really telltale with both of them. And with both of them, they will follow right along with prompt. Now, that doesn't mean I can use multi-word utterances still, because we are working towards their being able to say it on their own without the prompt, of course. So we're working in smaller units, and as typical with apraxia, the longer the unit, the more the motor planning difficulties that we see. Both children prefer well-rehearsed words. One little guy, they come in, the 12-year-old, he comes into therapy and they bring the list of words we want to work on. So everything has to be super functional. There's no point me trying to rehearse with him words that are very motor feasible, but yet they don't have functional value for him, or he won't use them. So I ask for the functional words, and I prompt it in, it's over and over and over. He comes for half an hour, and we might spend that half an hour with about maybe 3 or so words, where I'm putting them in different contexts, different games, different activities, and just getting a lot of practice. Same with the little girl, but she's not really able to request this herself. The mom will request useful words. Oh no, I lost my train of thought. There was something else I was going to say. Any specific question that you want me to answer about? Oh, the other thing about both of them, they're very sensitive, shall we say. So I'm always walking a fine line. I want to get as much out of them as I can, without pushing them over the edge. So, we'll try, and if there's something that's a little too difficult, the little girl will just stop and cry, very, very sensitive, and then, I lose her for 5 minutes. Whereas the little boy, he'll smack me, right? So, I'm always walking that fine line with getting as much as I can without pushing them over the edge. So I get so much from their eyes, like I can read it when I have to back off. But as far as the motor planning goes, I find prompts are so helpful, because it guides the motor movements. When the child doesn't know where to go, even for initial position, you can put them in an initial position, even if it's just to hold the jaw closed. Maybe they have jaw open, or the jaw is sliding, or whatever. You can get them in that initial position, and then you can start moving them. So did I answer your question?
No, absolutely.
That kind of rambles.
Well, I'm wondering, just out of curiosity, did anybody else experience Brianna was wanting?
Yeah. So I just wanted to say, as far as when my little one came to me, and she wasn't verbal at that point, and I'm Brianna Waldrop, by the way. I'm the owner of Apraxia Dallas, and I'm a graduate of the Apraxia Kids Intensive Training Institute. So for those kids, we have a number of red flags now for apraxia, from the research, from Megan Overby's research, and from some other researchers where they've gone back and looked retrospectively for early signs of CAS in our kids. So I use that. I do kind of a parent interview screener, where we go through and look. And since I've done this, at this point with dozens of children, then I kind of have an idea of how many red flags kind of warrant, hey, let's go ahead and start treating this as if it is apraxia of speech. So at that point, if we have a high number of red flags, and it's things like, a very small phonemic repertoire, and, a really big receptive expressive language gap, other motor deficits, other neurological, soft neurological signs, things like that. Then we go with a working diagnosis of suspected CAS, and start taking that motor learning approach, treating it as if it is, while we're of course also making sure that we have a strong emphasis on AAC. But so that's where I kind of start, is we parent interview, looking at red flags, see what the child's able to do, and in this case, she wasn't able to do a lot, so we were going on parent interview, but enough to say, hey, it's suspected, let's take this course of treatment. And then over the course of treatment, as she started making progress, then we could actually assess for more of those actual characteristics of apraxia of speech to move then toward a confirmed diagnosis. But for this little girl, that took It was actually, I think, over a year because she started when she was 2. And so it was quite a long time, for a working diagnosis. But as far as clinically how we were treating it, we were treating it just the same until we got to that verbal ability point to actually be able to note those characteristics.
Thank you, Brianna. Yes, Taylor.
Well, my situation was, I mean, I don't know everybody's clientele, but my situation was a little unique because my client, her older sister has SAS. And so she came in at about 15 months, so super early, which is really, really great to see. And we just kind of came in with the assumption that she was going to have CAS. Based on the diagnosis that, she has SAS, I'm going to immediately go in and treat this as, okay, you're likely, based on what your sister's profile is now, going down this path of, a severe childhood apraxia of speech. And so, I brought her mom and sister in, and mom was the go-getter and wasn't going to leave here without being like, is this how we're going to treat it? And I said, absolutely. We know what's going, what the future looks like, and you coming in at 15 months is going to hopefully change that trajectory for your youngest daughter. And so by coming in early, by treating her as if it was any child with apraxia, I feel like the results have been quicker, the results have been different, and her trajectory is very much different than her sister's. And so I think, using those genetics and seeing if children, with the siblings, if they have it, I mean, I would highly recommend the parents to get in as early, earlier than 15 months is okay. I mean, as early as we can to start that motor imitation, to start that motor planning, get those things going. And I think that's why this sweet little girl is just making tons of good progress. And so how she came in, did I immediately diagnose her with childhood apraxia of speech? Absolutely not, because she was 15 months, but I knew where it was headed. And so we're going to treat it like it is from the beginning.
Excellent. Anybody else with any comments for their particular kiddo? Yes, Kim. If we have you muted. Oh. Kim, she's muted.
Okay, I'm unmuted now. Okay, sorry about that. I don't know what happened. I'm Kim Monero, and I'm in a private speech practice in Short Hills, New Jersey. And the little girl I work with, I just wanted to talk a little bit about how we use the Kaufman speech practice test here often. This is our lifesaver here. And it's just a good indication of, even if the child, like you was just saying, was up under 2 years old, if they're not imitating sounds, if they're groping and they're struggling and their receptive skills are stronger than their expressive skills, you just know where to start. So I love using this technique here because it just gives you goals where to go next. Now, I know some of the sounds here aren't in the child's everyday vocabulary, but that's where I ask the parent, we want to keep it functional. We want to make sure we are talking about what is important to this child. That is what will make this child speak. So although I use this to blend sounds together and work for repetition, I always start with what is important in that child's life. So taking pictures of what is most important and working on those, simplifying if the word is too hard for them to say, simplifying it to the simplest form that that child can say and working on it over and over again. And in time, I mean, it's amazing how much progress this little girl has made with a great family behind her, and just how many times she has to say the words over and over. And she's now communicating. She has so many words. She can tell us what she wants. And when she came in, she was getting very easily frustrated. She didn't really want to talk to us. And now she is just lights up and tells you what she wants. And so I really feel between the Kaufman approach, using some prompt techniques, and just motivation. is what works for me.
Okay. Michelle, any comments on that similar thread?
It took so I'm Michelle. I'm from Jacksonville, North Carolina, north of Wilmington. I work with a 6-year-old little girl, and I've been working with her for about 4 years. It took her a while to actually demonstrate any patterns of any speech for quite some time. So I never officially diagnosed her with apraxia, but I've always done Kaufman apraxia, the visual, the verbal, the repetition. I hit a wall of defiance with verbal productions for a while, so I backed out on that because, you know, she only wanted to do sign or AUGCOM. So we've recently, in the last year or so, gotten back to verbal productions, her really responding well to apraxia cards. So with her upcoming like re-evals, like, you know, now would be a good time to give her that official diagnosis because I actually have more material, more examples, more patterns that I could actually provide. I have been using the apraxia approach for quite some time though, so.
One of the questions that our families have in general is when they're looking for a speech therapist, are they looking for a specific type of speech therapy? Do you think it matters at the beginning if they're finding someone who does Kaufman or who does prompt? As long as it's an apraxia type speech therapy, would that be a good start, or do they need to find one modality over another to be successful with their kiddos? Yeah, Brianna. Oh, she's muted too.
There we go. I think you can hear me now. I would say, you know, we have the most research supported approach for severe apraxia of speech, which when I say severe too, it's like it could be that child's severity, but also a lot of our young children who are just starting out at that point in their journey, it's severe. And so we have the most research evidence for dynamic temporal and tactile cueing as our approach, or DTTC. For that one. But so that I think would be great if you find a therapist who's well versed in that approach from a research perspective, and also from my clinical experience. That's a great place to start. But there's also a lot of research that says that the methodology that your clinician is the most experienced and comfortable with is also a big indicator of the success. So if your therapist in your area is prompt certified, or does do Kaufman and is really well versed in that, or DTT, whatever the case might be. So I think for parents, it's like each child has a different fit. Each clinician has what they're really expert in. And also what might work for your child at this stage is not necessarily what's going to be the best fit for your child in 6 months or 2 years. So it's kind of like, yes, we want something that's got good research evidence, but it's also kind of looking at interviewing your SLP about their expertise.
Okay. But would you say finding a speech language pathologist that has some apraxia specific experience would be a good start for a lot of our families? Is that,
Yes, that definitely. That's our start with apraxia experience, and then the exact apraxia methodology, there could be more open to that. But I definitely think taking a motor approach from an apraxia perspective is definitely the way to go, rather than more of a linguistic approach or something that's not motor based.
Does anybody else have agree or disagree with that? Anything that they would want to add to that? Yes, Taylor.
I just wanted to say for all our sweet parents is I would really encourage them to be present in the sessions, however that may look for different therapists. But I think the only way to know if your therapist knows what they're doing is to see what they're doing. And I think that having that parent coordination with the SLP is the most vital part of therapy, because I'm only seeing your child for a small part of their day, and I need you to be their therapist / mom / dad outside of the clinical setting. And so I would say you're going to have that gut feeling if what your therapist is doing is working. And so I would say follow your gut, you know, be as a part of the sessions as you can. I think if a therapist is like right away, oh, you can't be in my sessions, you know, I would red flag, oh, why, you know, look at the reasoning behind that, you know, okay, well then can you video my sessions? Can we zoom in now that we have Zoom? Can you zoom in? You know, really encourage parents to be a part of it and to listen to their gut, because I think that'll tell you a lot.
Okay. I saw a lot of people shaking their heads in agreement with you during that. So I don't know if everyone can see that, but I wanted to make sure. Ashlyn had a comment there too.
Just really quickly, in the publishing of this data in clinical genetics, we got edits back on some suggested things to change about the paper. Originally in my recommendation, I said, just get an Apraxia approach, just get a motor planning approach. And one of the editors came back and said, are you aware that there has been a randomized control trial on 2 Apraxia approaches, and that's the gold standard in research? And it's like, yeah, okay. But realistically, as clinicians, that doesn't mean that because there's been one randomized control trial of these 2 different Apraxia programs out of Australia, that those are the best. It just means that they've been researched as a randomized control trial. And so if any of you have read this paper and are looking for someone who does the Nuffield dyspraxia program or the rapid syllable transitions treatment program, it doesn't mean that I endorse them. It's just because the editor said we have to put the gold standard in here, and they're probably great programs. I am familiar with neither, but I just wanted to add that and clarify that in the publication of this research.
Great. Thank you. Yes, I'm trying to, yeah, we get everybody. Go ahead. Michelle, I'm sorry, you're on, I'm sorry. Yes, Michelle.
Add to, you know, what parents are looking for. Since SATB2 is not something that most speech therapists even hear about, I think that when a parent comes with, parent education is very important there to provide to the speech therapist as well. Like, can I give you all the information that I know? So, you know, Apraxia approach or sign or verbal, and kind of interview your therapist and see if it's going to be a good fit, because some therapists have certain niches and we all have certain things. And if the therapist isn't willing to do an Apraxia approach, or it's not really their niche, then it might not be a good fit. So not necessarily somebody with Apraxia, you know, that's well-versed in Apraxia, but do you have a speech therapist that's willing to do that? That's willing to do all modalities? Like, oh, well, if the kid needs, you know, more sign, I'll learn sign with them. If they need a Apraxia approach, then I'll do the Apraxia trainings as we continue to go. And because you don't want a speech therapist that also doesn't feel like they're making a difference too. So it's important for that parent to be picky in their therapist as well.
Kim.
I just also wanted to touch base upon, as a parent, if your child really is giving you a hard time about going to speech constantly and is lack of motivating, is feeling not motivated, you know, sometimes as a speech therapist, we have expertise in Apraxia or have autism. But if you feel like that therapist is not connecting with the child, it's okay to move on. We have 12 therapists here, and sometimes it's just not a personality fit. And that's okay as a parent to say, you know what, could I give somebody else you know, try somebody else? I feel like my daughter doesn't feel motivated anymore. And that's okay, you know? So I just feel as a parent, you're allowed to look for new therapists, see how motivated your child feels, look at the progress. That's really important in the child's life as well.
That's awesome. I think parents need that permission from time to time, because it's hard if you feel like you're letting people down. So I appreciate you saying that. Deborah, I saw your hand raised a second.
This sort of goes back to, it jogged my memory when they were talking about control studies. Just last week, there was an RCT study came out with Apraxia using prompt by Aravind Namathivayam. In the Journal of Natural Sciences or something. But anyways, that can be looked up, and if you're looking for more RCT studies and Apraxia.
Okay. Thank you very much. We have about 16, 17 more minutes, so I'm going to move on to a different topic, if that's okay, unless anybody has something specifically they're wanting to add to that. So what about sign language? Pros, cons of AAC, adding that sort of stuff in. Does that hurt progress? Does that help progress? What have y'all seen with that? I see a lot of thumbs up. Taylor, I know you have a little one. Are you using, with the very beginning stages, a lot of that?
Yes, so for my little one, her mom is very well versed in sign language. And so she came in with mom already like working on some signs with her because she uses some signs with her older daughter. And so, you know, she came in with signs, and I use a lot of gestures, not so much signs. So we're kind of doing like a mix of, you know, mom's helping me being like, oh, this is what she's saying, you know, because sometimes based on the motor planning, we have to change the sign up of how do my hands move, how do my arms move. And so you were always working together of, hey, she's signing this, you know, or hey, you know, mom, I'm using this gesture. What I just always encourage is always pairing the sign and the gesture with the verbal, and making that a non-negotiable, you know. And so with her, because she is verbal now, she's making tons of vocals. Every time she's signing or she's gesturing, there's some sort of vocal coming out of her mouth, because from day one, we set the precedent of, oh, you give me that sign, you give me that gesture, but we're gonna make a vocal too with it. And so I think that's been really positive, and mom's been really able to carry that over. So I, you know, using all modalities, using them in coordination with each other is my go-to.
Michelle, and I'll get to you next, Brianna, but Michelle, I know your client is particularly, has been particularly successful with sign language. Is that correct? Can you tell us a little more on that?
Yeah, so we were hitting a little bit of behaviors with trying to force verbalizations for the longest time. And so once we kind of started collaborating early visuals all the time. She actually received a sign interpreter that was with her in the school. So it sped up the process pretty quickly. And I feel like as soon as she started signing and you would figure out what she was saying, she could say, yeah, and she still can. So you're like, oh, you want red? Yeah. So then she started confirming that her communication was understood. A few things about her sign was that her fine motor was still requiring some attention. So I'm pretty fluent in sign language. However, sometimes I still have some difficulty. And the minute she's not understood, there's a little bit of shutdown there. But the more that she's practiced it, the more her behavior has increased. Her ability to want to learn has increased. She loves coming to therapy. And now we're pairing, like Taylor said, the signs and the verbalizations. And a lot of times I do sign, verbal, AUDCOM just to make sure she can do it on all modalities. Sometimes I feel like it slows progress just a little bit. However, I still feel like as far as increasing word count or increasing MLU, but also we're still serving a purpose and filling in those blocks that were missed before. We're still at the early stages of first words and first word building and verb, noun, and a lot of times the AUDCOM can give MLU increase and the signs that more immediate, this is what I need. But I do feel like the sign has helped a lot, which we all know the cons of sign is not, it's not a global understanding of what they're saying. But on a day-to-day basis with caregivers, it's wonderful because we're learning her personality, we're learning what things she likes, and in that we can elicit more of like activities that she likes and really engage her in that conversation, which increases more opportunities for that verbal output and social engagement in general. So
I'm so glad to hear about that success. Brianna, I saw your hand raised. Did you want to jump in?
Yeah. So for my little one, we started with sign right away, and I'm not fluent in sign, and I'm always open and with tell parents that. Like I say, I have like about a 2-year-old signing vocabulary. So we jumped in with that, and just again, as Taylor is saying, to give like that immediate, let's go, let's get something going, and then as she well, one thing, then when she went to preschool, we ended up seeing some behaviors at one point, and a lot of shutdown and just behaviors that weren't typical for her. And what we came to realize was that her teachers at school weren't understanding her sign. And so she was not being an effective communicator, so she wasn't being seen and heard. And so once we kind of realized that and kind of problem solved through that, then those behaviors went away. So just something for parents to keep in mind. A big thing that, when we're doing sign, and I'm a big proponent of, we have to do something, because right away to get that child communication system, they need to be seen, they need to be heard, they need to be able to express themselves. And I've seen it help so much with confidence, anxiety, and things like that. And it's not giving up on speech. Like when we're doing sign or we're doing augmentative, it is not giving up on speech. We're still working on speech, and like I said, like Taylor said, we're always doing them all together. So we're not, and at this point with this little girl, let's see, it was a little over a year ago that I was like, I really feel like we need to be looking at a device, because her verbal speech was progressing, but I felt like she had so much more she could be expressing with a device than she could even with sign. And we didn't want to hold her back, and I just felt like we needed that scaffold for her. And she has responded well to that, although her speech has just skyrocketed in the past year too. So she's really done really great with both. But I just really want parents to know, like, it is not giving up on speech when we're doing these other methods of communication. And just because we're doing them now doesn't mean we're doing them forever. And so right now with our sessions with this little girl, we sign, we talk, and we use our device.
I saw a lot of head shaking yes with that. So I guess us parents need to take that to note, that it is not giving up. I needed that reassurance too as a parent. So I guess does anyone else have anything specific on that they wanted to chime in on? Or should we move to the next? Deborah?
Tell the parents what we want. Sorry, I think I'm muted.
Nope, you're good.
Am I muted?
You're good now.
Okay. Sorry, I'm getting a lot of rain here. I tell parents what we want is a good communicator. Speech is our first choice, but we're working for good communication. So what we use now doesn't mean we're always going to use, but if we can use something that will reduce the frustration now, we'll combine it with speech, but we have to do what's motorically feasible at this point in time. And if that fine motor control isn't quite there now, but yet still the ideas need to be communicated, we gotta help get those ideas out whichever way we can. But yeah, speech is our sort of goal down the road always, if not now. So, okay.
Okay, so the next thing that parents were hoping to get some guidance on is what constitutes good progress in speech therapy when a child is typically considered nonverbal. So if we have a kid that's considered nonverbal, what would be good progress showing us that we're making steps in the right direction for that kiddo with their therapy?
And
yeah, Kim?
And you mean like verbally, right? So you were going, so, okay. So I would say if the child is just starting to imitate more, they had no sounds, now they're starting to imitate. They're trying to approximate. They are just saying more sounds on a daily basis that start to then become words. And if they're getting their needs met from the family and from their peers or teachers, you know there's progress. Like you just see the child making more sounds, it becomes easier. Like all of a sudden a sound that was so hard for this child to say just comes out now more in a natural way. So I feel like if the child feels empowered by the sounds they're making, they just keep trying and they start saying more. And I just feel like you can tell. What I try to do with my parents is we keep a running chart of sounds, and then the sounds that become words, and then the phrases. So we know in a year's time, we started out with just a few, and now we have a whole list of words and phrases that the child is saying. So I think just by looking at the child's ability and the ease of saying it, is you could tell from progress just from there.
Yes, Brianna?
There we go. Now I'm unmuted. I would say too, like sometimes when a child is pre-verbal, we end up working on some kind of motor movement prerequisites. So some ideas of like, of how we can move in different ways we can move. So I do a lot of things like we're gonna move big, we're gonna move small, and I'm kind of laying the groundwork, and then we're working on being able to move our mouth big and moving our mouth small. So there might even be things where it's like not even sounds yet, but it's the prerequisites to those sounds. Because if I open my mouth big, and I know how to do that, and then I have the control to open my mouth little, then that's setting the framework for I open my mouth big when I say an ah sound, and I open it little when I say an e sound. So some of that kind of motoric control, and also understanding what these concepts mean as applied to movement, like how I move big, how I move little as applied to movement, how I move fast, how I move slow as applied to movement, especially movements of the mouth. So sometimes it's not even quite yet, you know, being able to necessarily make those sounds. And another thing is too, just being able to turn on their voice can be a sign of progress. So being able to phonate and just getting any kind of that vocal fold vocalization consistently on demand is also a sign of progress when we have a child who's really pre-verbal.
Okay. Yes, Deborah?
Just turning on your voice. For me also, a big thing is, a big stepping stone is turning on your voice and moving position while maintaining phonation. So for example, they can do ah and they can do b, but they can't do ba because the jaw has to move. So they have to be able to maintain phonation and coordinate that with movement of jaw or movement of lips or movement of whatever. And for some kids, that's a big stepping stone, especially with apraxia.
Okay, so we only have a couple more minutes, and then we're going to hand it back over to Ashlyn to finish up with recommendations. So can everybody do just maybe a 10 to 15 second comment on what parents can do at home to best help kids with their speech delay? Like what's your one recommendation for parents at home? What's the best thing to do? And I see you on here, Deborah, so will you go first? Oh, yeah.
Okay, so one thing we always tell parents is don't be on them all the time. You know, you have your special talking time. So here it's like everything counts in these 10 minutes where you've got mass practice or whatever. But other than that, there's a lot of modeling, a lot of praise, a lot of encouragement. If they say something that's not quite accurate, you might want to model it back and just leave it go, because you don't want them shutting down because they think you expect perfection 24/7.
Love that. Kim, any last minute kind of?
Yes, I'll go back to just making it as functional and motivating as they can. And I feel like the kids make most progress when you work on things that they absolutely love and simplifying it to the easiest way that they feel like they said it and they want to say it again. So I just feel like the children just in general are more motivated to talk about things that they love.
Okay. Taylor?
Yes, I mean, I'm jumping on Kim's train over here, but I mean, I would say get a list of their favorites. You know, what are their favorite words, favorite toys? Get those together, write them down, put them on your fridge and be like, this is what we're working on. So you have a visual of like, that's what I'm working on. And, you know, if you need to put all of those toys kind of away for a week or two, and that they're special. We're going to play with these every day during this time. But other than that, you can't play with them. You know, like these are the toys that we're going to use. And like Kim said, simplify. I am all for simplifying the words, making them as simple as possible but understandable to those around him. So, you know, I mean, taking something like bubble, and I'm not going to hold that child expectation to be bubble. You know, I'm going to bring it down. I'm going to say bubble. You know, it might just be bubba. It just might be uh-oh. You know, that's okay for now. We're going to build up. They're going to be able to build it up. But don't worry about simplifying their language to meet their needs, because they're going to feel successful when they're understood. You know, and so once they're feeling understood, then they're going to just soar from there on. So those are mine.
Love it. That's great, Taylor. Thank you. Michelle, any quick ideas for us?
I would say, and that's all great. I would have loved to have said all that too, but I think modeling, just model, whether it's, you know, Apraxia cues throughout your day, whether it's the signs, whether you're reading a book with your Occam device and then you take turns doing it, making it less work and just more fun. You know, they are learning that that's just going to be their daily routine. So just modeling it in general and saying like, hey, Dad at supper time, he talks about what he ate, and there was no pressure on the child to do it. Dad modeled it. So, you know, or also have a friend and they can come over and they can play, just making it all of the model, and the kids want to use it more. Like, oh wait, I want to do it now. So I just think modeling is so important, and simplified modeling, like they said.
Deborah, did you what?
Extension of that also, when you're modeling their target words, it's so important to model them slowly. You can talk your regular speech when you say, okay, come on, let's go get your coat. But if you're modeling one of their target words, think of it, I explained it to parents, it's like a dance. So you're trying to teach a whole dance. So if you're learning a new dance, you have to watch each step slowly and multiple times. So this is like a little dance in your mouth. So you have to show those movements, and the movement transitions slowly. So the continuance you can drag out. The vowels you drag out. You join it always. You don't chop anything up, but it's got to be a slow model. And that gives the child time to remember, some of these kids have slow processing too. So it gives them time to watch it and process. How do I get my mouth closed while I'm rounding my lips? How do I do this? That's the slow modeling is so important.
And it is 2 o'clock, and I want to be respectful of everybody's time. If anybody needs to jump off at this point, I understand completely. So I was going to give Brianna, did you have any quick comments real quick before you hop off, or are you good? Good, okay. And then, yes, Kim?
I'm unmuted. I just wanted to add to one more thing. We always anticipate what our child wants. As a parent, you want to just, you see that their cup is empty, you go to fill that cup. I just wanted to say one more thing about giving that child that opportunity to ask for something before you just automatically do it for them. So giving small amounts of cookies, juice, whatever it might be. I love Taylor said about hiding toys in that box, so they have to ask for it. If everything is right there for the child, they never come to us because it's hard for them to speak, and they need so many opportunities. So just giving small amounts and kind of hiding those toys a little bit in boxes and putting some things up on shelves always help my parents.
Okay, so Ashlyn, do you still have time to do the last few minutes of the recommendations?
I do. These recommendations are really global, again, because we didn't get a ton of time with these kids. When you look at SAS and the speech needs, if kids are getting less than 90 to 120 minutes of therapy, it's just not going to touch all the domains impacted from a speech language standpoint. So when we see kids in clinic, we provide them with a letter. There are many kids who are getting way more therapy than this. So this is taken out because we don't want a school district to say, oh, 90's fine. So we're very careful about that. But if you are getting less than 90, after meeting these kids clinically, I just don't think it's going to be enough speech therapy for a child. Receptive vocabulary skills show a ton of potential in these children as a whole, so that needs to be continually targeted through the years. As the clinicians were saying, you've got to do AAC. You got to give these kids a lifeline because verbal speech may not be acquired at all. It may not be easily come by. When it's there, it may not be intelligible because of apraxia. So we've got to give these kids some other modality. When doing IQ testing in school districts, that they need to be considered for nonverbal IQ testing, given that what we know about their verbal abilities. Apraxia of speech, these clinicians nailed it on the head. You need to at least be using an apraxia approach if you're addressing verbal speech, because it can almost be assumed. It's just that we see kids with these signs. I did not diagnose apraxia as part of my my clinic, but we saw signs of it in all the kids with verbal ability. So it needs to be assumed, and that needs to be the approach. Monitor resonance, because it tends to be a problem. Consider the kids for feeding therapy if they're having trouble with chewing and pocketing food. That was pretty universal. Monitor for aspiration of liquids. That can always be a hazard to lung health, especially if your child's having recurrent lower respiratory issues. That was common in this population. Consider an ENT referral if the drooling's persisting beyond 4 years of age. We saw a big trend of most kids who drool stopping at around age 4. And then the incidence of autism is higher in kids who have SAS. A lot of times I saw kids who I felt had undiagnosed autism because everyone said, oh, they've got SAS, that explains all of this. And then I saw some kids who carried a diagnosis of autism, but I didn't think that they had the hallmark features of autism. I thought that their eye contact and socialization and joint attention was quite normal, but maybe they somehow fit the criteria for autism. But sometimes everything that's going on in the big picture with your child may not just be SAS. Do not ignore signs of autism and pursue that diagnosis if need be to help, because there's a wealth of evidence that can inform practices if your child also has a co-occurrence of autism.
Yes, awesome. Thank you so much. Well, I'm going to just kind of bring this all together and say thank you all so very much for your time and expertise. We're just very appreciative, all of us parents, and are so thankful for any guidance we can get on helping our kiddos the best we can. So thank you very much. Allison, did you have anything you wanted to say to finish up, or is that?
Thank you guys all for taking the time out of your day today, for working with all of our children that you're working with, and helping to share the knowledge with our community at a larger scale. So thank you.
Appreciate it. All right.
All right. Thank you.
Bye, everybody.
Bye.
Bye.